In this part of our Neurologic Pathophysiologies lecture, we're going to actually look at a number of different types of pathology. So it's important that you be able to differentiate among the organisms as well as cerebrospinal fluid results of bacterial meningitis versus viral meningitis, and then also encephalitis. We're going to talk a little bit about intracranial pressure. We'll determine the difference between partial and generalized seizures, and then take a look at the more common types of headache you may run into in practice, including tension, cluster, and migraine. And then we'll end with talking some about concussion and traumatic brain injury. Let's start then with infection. When we think about infection within the neurologic system, the two big ones are meningitis and encephalitis. When we think about meningitis, remember this is infection and inflammation of the meninges. And this can either be a bacterial infection or a viral infection. In both of these, a meningitis infection has a rapid onset, which is very different from encephalitis, which has a more gradual onset. As we look at the bacteria, we know that there are some bacteria that are more likely to cause meningitis than others. The most common at all ages is strep pneumoniae. Remember, that's a gram-positive bacteria. Second most common is H. flu. The meningitis, the meningococcus bacteria itself, the Neisseria meningitis, which is a gram-negative bacteria. And then you may also see group B strep. What's important to know is that the organism will vary by age group. So for example, when we look at newborns and children, the predominant organisms are strep pneumoniae and group B strep. In adolescents and young adults, you're more likely to see Neisseria as well as strep pneumonia. In an elder, once again, strep pneumonia. We talked about that one being a commonality across all ages. But you will also again see a little bit of the meningococcus, the Neisseria bacteria, but you'll see more H. flu. The highest risk of bacterial meningitis is actually in infants. So as an age group, infants has the highest risk in terms of age. So with a bacterial infection from these bacteria, you have involvement of the meninges as well as the underlying brain parenchyma. When we diagnose a bacterial meningitis, the most important tool we have is the analysis of the cerebrospinal fluid. And one of the big things we're going to look at are polymorphonucleosides, or PMNs. And then we'll also look at the associated symptoms. In general, when an individual has a meningitis, they frequently present with, they may present with headache, they may present with neck stiffness, they may present with constitutional illness like elevated fever and very ill appearing. Generally, a meningitis is more likely to occur 3 to 7 days after exposure to the bacterium itself. With a viral infection, once again, still talking about the meninges and the underlying parenchyma, but we think about the viruses that are more likely to cause the infection, the meningitis rather. So we think about mumps, herpes, the echovirus. You'll also see this in HIV. Once again, the diagnosis is made via the analysis of the cerebrospinal fluid. And although we may see neutrophils early, we are more likely to see the lymphocytes later, as well as the additional associated symptoms. Individuals with a viral meningitis tend to be less constitutionally ill, less high temperatures, than you'll see with a bacterial meningitis. So let's take a look at the cerebrospinal fluid. As you can see, when you compare bacterial with viral meningitis, when you look at the components of the cerebrospinal fluid, they are quite different. So when we think about the opening pressure, every time you do a lumbar puncture, you look at the pressure of the fluid itself once you enter the colon. With a bacterial meningitis, you tend to see a higher pressure and a high pressure as opposed to an opening pressure within normal limits. In a bacterial meningitis, you see a lot of white blood cells. You'll see more than 1,000, less than 1,000 in viral. Glucose and protein levels are also very important. You tend to see low glucose levels and high protein levels in the cerebrospinal fluid in meningitis. In a bacterial meningitis. In a viral meningitis, these tend to be within normal limits. Now, there's another quick trick on this, and that is, even though we're looking at an absolute level here on the slide, you also have to think about what the serum glucose is. So if you have someone who is hyperglycemic, you look at instead of a normal level, you look at the 50% level. What that means is in a bacterial meningitis, the glucose level in the cerebrospinal fluid will be less than 50% of the serum glucose. In a viral meningitis, the amount of glucose in the cerebrospinal fluid would be greater than 50% of the serum glucose. So that's how you compensate for hyperglycemia. As you can see, in a bacterial meningitis, there's a lot of protein, not so much in viral. And part of that might be simply because of the size of the organisms. When we look at different cells, we see polymorphonucleosides or neutrophils in bacteria. In bacterial meningitis and in a viral meningitis, look for those lymphocytes. That's the key thing that you're going to look at. And I do think it's important that you have a sense of some of those components of the cerebrospinal fluid and what they mean when you look at a bacterial versus a viral. Let's turn our attention then to encephalitis. Now, an encephalitis generally is due to a virus, although it could also be toxic or it could be autoimmune. So when we think about an encephalitis, this usually has a more gradual onset than we see with a meningitis. Frequently, a viral encephalitis is frequently preceded by a flu-like syndrome. We may see it presenting as an autoimmune response after a viral infection, or again, this may be a toxic exposure. One of the most important things to take a look at is whether or not there are other viruses or other organisms affecting us. So in an encephalitis, we would want to consider herpes. We would want to consider the West Nile virus. Here in Texas, that's especially important. Also important any place where there are a lot of mosquitoes, because mosquitoes tend to carry this West Nile virus. We think about Lyme disease, Rocky Mountain spotted fever. All of these can cause an encephalitis. We also know that toxoplasmosis and cryptococcus can cause encephalitis. We should always be alert for the development of encephalitis in an individual with HIV and with AIDS. 15% of the individuals with HIV and with AIDS develop encephalitis. Now, unlike the meningitis, cerebrospinal fluid analysis tends to be pretty much normal. And that makes sense because with the encephalitis, we're talking about the brain tissue itself. The meninges are not inflamed. And so that's why you don't see a lot of changes on the cerebrospinal fluid itself. In addition, you're much more likely to see significant neurologic deficits in encephalitis as opposed to a meningitis. So as a result, with an encephalitis, the patient may complain of a more severe headache, photophobia. You may see some changes in level of consciousness. They may be confused, drowsy, and may actually also exhibit seizures. One of the ongoing concerns we have with many of the neurologic pathophysiologies is the effect of the pathology on intracranial pressure. So the purpose here is to talk about some major concepts with intracranial pressure, because you have to, the pathology is going to lead to the difficulties with the increased pressure. One of the things that we want to remember when we think about intracranial pressure is the Monroe-Kelly principle. And basically that principle is that the total volume in the skull is fixed. That makes sense. Remember that as an infant, when we are first born, we have a more flexible skull. Our sutures haven't closed. The posterior fontanelle closes about 1 to 2 months. The anterior fontanelle closes between 9 and 18 months. So that skull becomes fixed very early in our life. Because this total volume in the skull is fixed, the amount of space, for lack of a better phrase, we have within the skull is fixed, the individual components then compensate if there is pathology. And those individual components have to be the brain itself, the cerebrospinal fluid, and the blood volume. So that's where compensation has to occur if we need to buy some volume, for lack of a better phrase. So as a result then, we have 3 essential concepts when we think about what's going on within our skull. We have to think about intracranial pressure, we have to think about cerebral perfusion pressure, and we have to think about cerebral blood flow. They are all interrelated and they are all connected. So let's take a look at cerebral perfusion pressure. Cerebral perfusion pressure is the difference between the mean arterial pressure and the intracranial pressure. So it's the MAP, the mean arterial pressure, minus the intracranial pressure. So what we are concerned about with that cerebral perfusion pressure is the ability to auto-regulate. So that with cerebral perfusion pressure, autoregulation is key so that there's a constant blood flow rate by regulating the diameter of the arterioles. Our ability to autoregulate begins to fail when the mean arterial pressure drops below 50, because we're not perfusing, or greater than 170, and this is in an adult, because we are unable to constrict anymore to protect the brain. Our ability to autoregulate also fails with a sustained elevation of the intracranial pressure greater than 35 millimeters of mercury, because you're decreasing flow. We know that cerebral blood flow is dependent on cerebral perfusion pressure. So that cerebral perfusion pressure, the pressure difference across the brain between the incoming MAP and the opposing intracranial pressure on the arteries, is very, very important. We have to have that pressure gradient for cerebral blood flow and oxygen, as well as metabolite delivery. So if the cerebral perfusion pressure is decreased, we don't have enough cerebral blood flow. When we increase intracranial pressure, we decrease the perfusion pressure and the cerebral blood flow. That then leads to cerebral ischemia. And the pathology that causes the intracranial pressure, the increase in intracranial pressure, can either be inside or outside the cranium. Last but not least, one of the other things we want to remember about cerebral blood flow is hyperemia. When we have hyperemia, when you have a greater cerebral blood flow, you have greater metabolic needs, and that is also associated with an increase in the intracranial pressure. So knowing those mechanics become important in understanding the concept of increased intracranial pressure. So now let's take a look at some of the pathologies, a closer look at some additional pathologies. So we're going to talk about seizures, we're going to talk about headaches, and we're going to talk about trauma, specifically brain trauma. So let's start with seizures. Let's talk about the pathophysiology, and then we'll talk about how it occurs and what to look for. So when we think about what a seizure is a transient disruption of electrical function. And because there's a disruption of the electrical function, there's an excess discharge of those cortical neurons. So what you've lost then is a balance. And with seizure, you've lost balance between excitation and inhibition of impulses. And that balance between excitation and inhibition has been disrupted. When I think of a visual picture of a seizure, especially a tonic-clonic grand mal seizure, what we frequently think of that, I think of a light switch being turned on and off very, very rapidly, because you've got an imbalance, a disruption between excitation and inhibition. Now, this can be due to a number of different things. This may be due to membrane instability. This may be due to channel defects and the ability of potassium or calcium to move across the cell membrane channels. It could be due to the lack of inhibition of GABA. Remember, gamma aminobutyric acid is an inhibitory neurotransmitter. So if GABA is not inhibited, you're going to have essentially excitation. It may also be due to enhancement of NMDA, which is excitatory. NMDA, or N-methyl D-aspartate, is a receptor. When that happens, when you stimulate this receptor, it allows positive ions to enter and flow across the cell membrane. Therefore, you have more excitation. Now, seizures are fairly highly synchronous, and it's a very synchronous process. So the seizure is initiated, something gets it started, and then it becomes propagated across and through multiple neurons. You have the formation of and what happens then is you actually form a chronically hyperexcitable network. And that's what causes a seizure disorder, is this chronically hyperexcitable neuron network. That's what a seizure disorder, a long-standing seizure disorder is, as opposed to an acute seizure due to underlying pathology. So what sorts of pathologies may lead to seizure? Well, some of them are secondary, and then we'll also talk about the primary. So when we think about secondary pathologies that can lead to seizure, certainly one of the things would be a cerebral lesion. A mass effect, so a brain tumor, a tumor within the brain, can manifest with a seizure. 50% of individuals who have a tumor will present with a new onset seizure. This could be due to a biochemical alteration. With hypoglycemia is the most common biochemical alteration to think about when you think about someone with a new onset seizure, because remember that brain needs oxygen, so you've altered their chemical environment. And then certainly, last but not least, head trauma. We know that head trauma can cause seizure. Certainly increased intracranial pressure as a result of trauma could cause seizure. The most common primary disorder that causes seizure is epilepsy. And what this means, with an epilepsy, there is no underlying correctable cause. And these seizures due to epilepsy can either be focal, which is more localized, or they may be generalized tonic-clonic. One of the things you want to remember about seizures in general is that seizures can lead to an imbalance between the metabolic need and the cerebral blood flow. And if you imbalance that need and the blood flow, you have an ischemic process. So if we look at things, if we kind of pull that apart a little bit, that this uncoupling idea, you look at an increased need. So an increased need on the metabolic side, seizures themselves increase the metabolic need. Hyperthermia increases the metabolic need. Fighting against restraints increases the metabolic need. This can then lead to ischemia and then further seizure. When you decrease the cerebral blood flow, that is then going to potentially lead to increased intracranial pressure as well as significant hypotension, both of which once again can lead to ischemia. So let's take a closer look at a couple of different kinds of seizure. Let's look at generalized tonic-clonic, and let's look at partial seizures. With generalized tonic-clonic seizure, you're looking at tonic-clonic motor movement of the extremities. This is what we'll see in what we traditionally think of as primary epilepsy. We also think about this in terms of febrile seizures. This is what a child would experience or manifest with a febrile seizure. Generalized tonic-clonic motor movement seizures are virtually always associated with mental status impairment, as well as frequently associated with focal neurologic or localized neurologic deficits. Many individuals following a generalized tonic-clonic seizure will have a post-ictal phase where there is a decrease in the level of consciousness while during a recovery period. Partial seizures are also called focal seizures. Now, partial seizures may or may not include any motor activity, and in fact, the clinical findings of a partial seizure may be very subtle and can be missed. Partial seizures are usually separated into simple and complex. With a simple seizure, this may involve very short, limited motor activity and or maybe primarily sensory. What's important here is, unlike a generalized seizure, there is no loss of consciousness. In a complex seizure, these are more likely to be in the temporal part, time-related, and also in the temporal portion of the brain, or they may be psychomotor. Now, complex seizures frequently are associated with an impaired awareness or an impaired conscious awareness of what is going on. Complex partial seizures may be associated with lip smacking, chewing, fidgeting, and the individual is not aware of these motor symptoms that they're exhibiting. They aren't aware that this is happening. One of our concerns with long-going seizure, and this is with generalized tonic-clonic seizure, is status epilepticus. Status epilepticus is a potentially life-threatening pathology. Status epilepticus is defined as 5 or more minutes of continuous clinical and or electrographic seizure activity, or recurrent seizure activity without recovery between the seizures. So there's a lot of ors there, but the idea here is you have unremitting generalized tonic-clonic seizure activity, either observable or electrical that you can see on an EEG or an EMG. What happens during status epilepticus and makes it deadly is that the glucose and the glycogen stores are very, very rapidly depleted. Remember that the brain doesn't have the ability to store a lot of fuel, so the brain lacks those stores. So it has a constant need for glucose every day, and we use a lot of our glucose just at rest. With status epilepticus, there is a huge increase in cerebral metabolic rate. So not only are we using a lot of glucose, we're also using a lot of oxygen. Remember that glucose and oxygen is going to be gone very, very quickly. We need that energy for transport. We need that energy to maintain the sodium-potassium membrane potential, as well as healthy transmission of nerve impulses. So what happens with a status epilepticus is there's an ongoing trigger stimulus that evokes this activity. In stage 1, frequently you'll see the generalized tonic-clonic seizure. There's a lot of autonomic activity and a huge amount of cerebral blood flow. And this is usually very observable. However, what happens in the brain in stage 2 is you start losing that autoregulation. With the loss of autoregulation, there is a decrease in the cerebral blood flow and an increase in the intracranial pressure. At the same time, there is an associated hypotension, so we know we're losing perfusion. This then leads to continuous electromechanical dissociation, and that may manifest itself as twitching. So what's really scary about status epilepticus in the treatment environment, again, this can happen in children as well as adults, is when someone comes in with a generalized ongoing tonic-clonic seizure, we give them Ativan or we give them Dilantin. What that does is it suppresses the tonic-clonic movement, but it doesn't suppress what's going on in the brain. That's why that characteristic of what's going on the electrical activity of the brain is critical to identifying what's going on with the use of oxygen and glucose within the brain. Because just because you don't see the motor movement anymore doesn't mean the brain isn't still discharging very, very rapidly with that electromechanical dissociation, which may or may not show up as twitching. Potentially life-threatening. So let's talk about things that aren't life-threatening then. Let's talk about headaches. Headaches is an incredibly common complaint, and if you work in primary care, you're going to see a lot of individuals with headache. The 3 types of headache we'll talk about are migraine, tension, we've all experienced those, and cluster headaches. Let's start with migraine headache. Migraine headache is neurovascular. And when we think about all headaches, but especially migraine headaches, we want to think about the pattern of the headache, the onset, and the severity. With many headaches, we want to know what the triggers are. What triggers these headaches? Now, with migraine headache, we know that there are numerous causes, and there may also, once again, be genetic predisposition. You'll see that several individuals in a family will have migraine headache. We know that in this neurovascular type headache, there is a reduced threshold for triggers, and there are many different types of triggers. Triggers can be anything from a food like chocolate, wine, milk. It can be fatigue, stress. It can also be hormones. We know that when we look at migraine headache, that a migraine headache is 3 times more likely in women after the age of 25. And as a result, we've looked very hard at estrogen, and estrogen has indeed been implicated as one of the triggers for migraine headache. We know that this is probably associated with the vascular effects of estrogen during the menses. Now, migraine headache may be associated with aura, or it may be without aura. And those are the 2 major big buckets of migraine headache, with aura and without aura. In general, individuals who have aura have an aura that is less than an hour or equal to or less than an hour. And we're going to talk about that in just a little bit. Importantly, it's migraine headache, even though it is neurovascular, is not associated with neurologic deficits. So you don't see paresthesia or dysesthesia or things of that nature. Most migraine headache has some specific phases or stages. The premonitory stage, they may have an aura or may not have aura. Then there's the headache itself and the recovery. So premonitory phase are those symptoms before the headache actually occurs. And most people sort of may have a very vague and not real specific idea, but they begin to sort of understand that. Now, premonitory is not aura, but it is sort of some vague symptoms that occur before the headache. We're not completely sure, first off, we're not completely sure exactly what causes migraine headache, but certainly we don't have a good understanding of what causes this premonitory phase. But we think it may have something to do with the dopaminergic or the hypothalamic regions of the brain, those dopaminergic receptors and the hypothalamus. With aura, those individuals who have aura, this is a spreading focal, localized sensory or motor disturbance. And most people have the same aura. Aura is most likely due to vasodilation followed by vasoconstriction. It also is associated with decreased electrical activity, decreased blood flow from the cerebral cortex to the occipital area. So with aura, one of the things we're looking at then are neurotransmitters and the production of neurotransmitters. Frequently with aura, there are low levels of serotonin. Serotonin causes vessel constriction. Therefore, without the serotonin, you have vasodilation. So that may be one of the neurotransmitters that is associated with aura. The next stage and the other piece of aura may also be associated with the inflammatory response. In the inflammatory response, you have vasodilation and an increase in capillary permeability. This inflammatory response, this vasodilation with increased capillary permeability, may be one of the major components, may be a significant component that leads to the third phase of headache and causes that throbbing headache. Migraine headache is associated with pain that is unilateral, of a throbbing nature, and may be associated with additional symptoms. The additional symptoms that migraine headache are frequently associated include nausea, vomiting, sound sensitivity, light sensitivity, fatigue, may even be some visual changes. In general, and so you have both these central, as well, you have concerns about both central and peripheral mechanisms as well as vascular and non-vascular components of the headache. In general, migraine headache lasts anywhere from 4 to 72 hours. Following the headache, and that's why the abortive therapy is so important. Recovery of the headache, again, fairly variable in time, can last several hours or can last more than a day. And the frequency of headache, of migraine headache, varies a great deal. As many of you probably know, there are neurology practices that have specialized in migraine headache or headache management in general, because it is such a common complaint and issue. One of the things we want to remember about migraine headache is those individuals who have migraine with aura have an increased risk of stroke. So that's something we want to be very alert for. We also know something about tension headache and cluster headache. Now, tension headache is the one that we probably have the most personal experience with, I hope anyway. Tension headache has a bilateral pain distribution, generally of a band or pressure-like sensation that has a gradual onset. So a tension headache is pretty widely distributed, and you can see it worsening. So it has that gradual onset. Now, there's a suggestion that there may be some genetic predisposition to headache. I was talking to a colleague, who had chronic headaches, and he ended up realizing that he had migraine headaches. But as a child, he just thought headaches were normal, and he didn't know until he got into high school and later that not everybody experienced headaches. So you think about that genetic predisposition. Are there a lot of headaches in your family? And tension headaches may be episodic or they may become chronic. When we think about tension headaches, we think about two major components, the trigeminal hypersensitivity, which is a more central mechanism, or the myofascial afferent sensitivity, which is more peripheral. Cluster headaches are very different from tension headaches. Cluster headaches are actually sort of a group of disorders in which the individual experiences very painful headache for several days, followed by remission. And this remission is characterized by no headache activity, and it may be several months. Now, cluster headache has a unilateral pain distribution. Remember, with tension headache, we talked about bilateral, but migraine was also unilateral. This has a sudden onset, but has a short duration. Most headaches themselves will last 30 minutes to 2 hours, but then you'll have another headache the next day for several days. The other thing that's interesting about the cluster headache is it may be associated with ipsilateral, same side, lacrimal tearing, ptosis, and nasal stuffiness during the painful part of the headache. And remember, these tend to be short, but you'll see that ipsilateral associated symptoms as well. What we think is happening with cluster headaches is that there are three major mechanisms. One are the activation of vasoactive peptides. So there again, you've got that idea of vasoconstriction. You have the idea maybe there's an inflammatory response, neurogenic inflammation, and the peptides and the inflammation activate pain pathways. Cluster headaches also tend to have triggers, and many of the triggers for cluster headaches tend to be very similar to the same triggers that cause migraine headaches. So things like stress, lack of sleep, ingestion of certain foods, things of that nature. The last topic in this section is traumatic brain injury or brain trauma. So we're going to talk about a couple of different pieces here, and some of these are absolutely definitional, but you have to have a good sense of some of the negative things that can happen with brain trauma. So when we think about traumatic brain injury, we think about both closed as well as penetrating injuries. A closed traumatic brain injury means that the dura mater remains intact. A penetrating traumatic brain injury, the dura mater has been interrupted by the injury mechanism. We know that with traumatic brain injury, there is the risk of either subdural or epidural hematoma. And this is the collection, and as the collection of blood in the space increases, the negative symptoms of the traumatic brain injury also increase. So with a subdural hematoma, the epidura in a subdural hematoma, the hematoma, the bleeding expands toward the skull. In an epidural hematoma, the hematoma actually strips the dura away from the lining, from the skull itself. So think about the epidural lining, and it's being stripped, that dura is being stripped away from the skull itself, as opposed to the subdural hematoma, there's expansion toward the skull itself, underneath the dura mater itself. Concussion is a diffuse axonal injury, and the severity relates to the amount of shear force that occurs during the injury itself. So let's think about a couple of different kinds of injury. We have acceleration-deceleration injury, and we have coup-contra-coup injury. And when we look at acceleration-deceleration, we're looking at object and head. So with an acceleration injury, the object hits the head. With a deceleration injury, the head hits the object. So this is one of the things we're concerned with in sports injuries. But this can also occur in a motor vehicle accident. This can occur during a fall, all sorts of things. So if we think about an acceleration injury, the object hits the head, the ball hits the head, the football helmet hits the head. When you think of the deceleration injury, the head hits the object. So it's the individual who was tackled and they fall and their head hits the tarmac or hits the playing surface. With coup contra coup, you're thinking about what's happening inside the brain or inside the skull. With a coup injury, the blow to the head and the injury to the brain are on the same side. With the contra coup injury, the blow to the head and the injury to the brain are on opposite sides. So you think about a contra coup injury, think about a motor vehicle accident. So the head, you've had a head-on collision and the head snaps forward. So in that snapping forward in the motor vehicle accident, the blow to the head was on the steering wheel, but the brain bounced back against the back of the skull, and so there's injury on the other side or the back of the skull. Hope that made sense. So it's coup contra coup. Coup means the blow and the injury are on the same side. Contra coup means the blow is on one side and the injury is on the opposite side. So as we think then about concussion, we also want to think about post-concussion syndrome. There's a lot of interest in that in sports circles right now. But we also want to talk about comparing and contrasting that with chronic traumatic encephalopathy. Let's look first at post-concussion syndrome. With post-concussion syndrome, these are the effects of the concussion. Generally, this lasts for 7 to 10 days after concussion and usually resolves within 3 months. This is associated with complaints of headache, decreased attention span, and may also be associated with complaints of nausea. Now, our concern with post-concussion is that the effects of concussion are cumulative if the individual returns to the sports activity and puts themselves at risk for the same kind of injury if they have not recovered. So the effects of concussion are cumulative if they return and get another injury without recovery. Now we know that the younger the individual is, the greater the recovery from the injury. So high school age recovery is greater than college age recovery, which is greater than someone who is a professional athlete in their 30s or 40s. Now let's compare let's compare that with chronic traumatic encephalopathy. Chronic traumatic encephalopathy is a progressive degenerative disorder that results in the loss of brain tissue mass. This occurs after 5 to 18 years and is actually a potential result of ongoing concussive injury. It's estimated that this occurs in about 87% of boxers, 5% of soccer players, and 60% of football players. High school athletes that sustain repeated concussion are 3 times more likely to develop chronic traumatic encephalopathy than athletes who do not sustain concussion or that don't recover from concussion. That's a better way of saying that. So what I talked about was with this chronic traumatic encephalopathy is there's a progressive degenerative process that results in the loss of brain tissue. And this is due to the accumulation of tau protein. What happens with this accumulation of the tau protein is the stabilizing cell structure becomes defective, and as a result, there's interference with neuronal function. This results then in memory loss, an increase of impulsive behavior, loss of balance, dementia, and impaired judgment. And if you think about where this has been in the news, there are two places where this CTE has been in the news. One is with the development of Parkinson's disease, and this is what we think happened with Muhammad Ali. The second is one of the football players, I think his first name was Victor Sayao, but he actually demonstrated a lot of impulsive behavior and ended up becoming severely depressed and took his own life. So post-concussion syndrome is something that happens after concussion, and it takes time for the brain to heal. Usually takes 7 to 10 days, fully resolves in most individuals within 3 months. And it's important that we recognize that the effects of these concussion can be cumulative if there is no recovery. Without recovery and ongoing concussive effect, this can lead to chronic traumatic encephalopathy, and that's our big concern. Now, you know that I'm very interested in biomarkers, so I had to bring this up one more time. There's a lot of interest in potential biomarkers, and the two biomarkers that are getting a lot of interest are BNDF and GFAP. BNDF is brain-derived neurotropic factor. BNDF supports the survival of existing neurons and has a role in the growth and development of new neurons in synapses. It's very active in the hippocampus, the forebrain, and in the cortex. So we know that because it supports the survival of the existing neurons as well as important in growth and differentiation, and where this occurs, we know that we need this for learning and memory, and our executive functions. So this is essential for long-term memory. What they've identified is that there is a correlation of BNDF and recovery of concussion. Low levels of BNDF predicted failure to recover from a concussion syndrome. So as a result then, we're beginning to see whether or not we can use that to determine not only the existence, but also the severity of traumatic brain injury. And this is traumatic brain injury in general, not just a concussion, but all forms of traumatic brain injury. CFAP, or glial fibrillatory acidic protein, is a protein that has been identified after a traumatic brain injury, and we've identified that it tends to increase within 6 hours after the injury. This has primarily been tested in children with traumatic brain injury. An increase in CFAP has been associated in children with both the existence as well as the severity of traumatic brain injury. In this part then, we've talked about a lot of different pathologies, and it's important to be able to separate them all out. We talked about the two main kinds of infection, meningitis versus encephalitis. We talked about 3 different kinds of seizure. We talked about 3 different kinds of headache, and then we spent a fair amount of time just now talking about traumatic brain injury, especially talking about concussion and chronic traumatic encephalopathy. So it's going to take some sorting out. And as you sort all of those out and put it back together with other pathologies that we talked about with stroke and bleeding into the brain and those pieces, we also want to think about the potential effect of all of these things on intracranial pressure. And remember that when we think about intracranial pressure, we want to think about those components: cerebral perfusion pressure, cerebral blood flow, and intracranial pressure. Very dynamic, and they all affect each other. I thank you again for your attention, and as I always do, I welcome your questions.